All right, so I'm Stuart Swadron, and for the next few minutes, we're going to talk about the emergency medicine approach to headache. These are the objectives that we're going to cover. We want to know what all the really important critical diagnoses for ER doctors to pick up are, just very briefly what their treatment is, and what features on history and physical we need to be looking for, the red flags, so to speak. And then we'll talk just a little bit about the indications for imaging as we go through, and the interpretation of a few CT images and a look at CSF. So the two objectives that we have clinically when a patient comes in with headache is to make them feel better, number one, and two, to make sure it's nothing serious before we send them home. And of course, we're going to end up sending home probably about 98% of these patients with headache. Remember, headache is one of the most common chief complaints that shows up to an emergency department with about 3 million visits a year. So this is something that we see a lot of. Now, in terms of the treatment, I'm mentioning treatment before diagnosis, and that's because that's kind of how we need to approach this. It's very hard to work up a patient who's in agony, holding their head, and get an accurate history. And the other point is that there's no diagnostic value of their response to therapy. And so many different medications will be effective against headache, and they'll be effective against all sorts of headaches, be they very serious, secondary, worrisome subarachnoid hemorrhage, or be they non-worrisome recurrent tension headaches. They will all respond to a large degree to these treatments up here. And so the most effective medications of all are the dopamine antagonists, and those should be, in most patients, a first line. Again, regardless of what you think the etiology of the headache is, it's probably reasonable to start there. The other medicines here are also effective to lesser degrees, and you have to tailor the approach in each patient because, for example, they might have already had one of these medicines when they present to you. So I'm not going to belabor it much more than that, other than to say that you need to get rid of their pain, and you got lots of strategies. The other one comment I would make that we notice across different medication classes is that the faster the medication gets to the brain and the earlier in the headache, the better the chance you have of getting rid of the headache. That's an important concept. So intravenous medications like prochlorperazine, of course, which is one of the most useful dopamine antagonists, are much more successful than intramuscular, which are much more successful than oral. And so the faster it gets to the brain, the more effective it generally is. And as I mentioned, there's no diagnostic value in general to be obtained by the response to therapy. So just because someone gets better with prochlorperazine, for example, that's sort of my go-to drug, doesn't mean it's not a subarachnoid. It doesn't rule it out. Now, I did mention these terms, primary and secondary headache, and everyone needs to know what those are. Primary headaches are headaches that are recurrent and they don't kill the patient. These are chronic headaches. Secondary headaches are everything else, things that are caused by identifiable pathologies like tumors and bleeds, and they are generally speaking of concern. Now, I don't care too much about how emergency doctors characterize a primary headache. The fact that it's recurrent and that we can make it better, that's good enough for me. And I don't need to actually make the actual distinction. But sometimes on examinations, they do tend to focus on some of the classic features of the different primary headaches. Migraine, of course, is characterized by neurologic symptoms, quite frequently scintillations, perceptions of colored flashing lights, things like that, and other neurologic syndromes. But the thing is that when it has an actual hard neurologic finding, like weakness on one side or some visual defect, you have to assume that it's a stroke. And any of these migraines with neurologic hard findings are strokes until proven otherwise for an emergency doctor. Only the neurologist really can make that diagnosis after extensive testing. Now, cluster headaches are also very characteristic, but again, they will respond to similar therapies as migraines. What makes them very classic for an exam question is they tend to be males, as opposed to migraines, which tend to be females. Cluster headaches tend to be extremely severe, lancinating pain that occurs behind one eyeball, often associated with watering of the eye. And the reason they call them clusters is that they occur again and again and again in a short time period, over maybe days or a couple of weeks, and then they go away for a while. Again, they respond to very similar treatments as migraines, the list that we just showed you, but specifically you might be asked about this. They do also tend to respond to oxygen up the nostril that the side of the headache is on, lidocaine in the nostril that the headache is on also tend to be special things that are effective for clusters. Tension headaches can be very similar and hard to distinguish from migraines, and they respond to similar therapies. Tension headaches don't have an aura, for example. They will never have neurologic features. But again, you could have a very hard time distinguishing the two, and you don't have to. You can just write primary headache. Now here is the meat of the matter. And this is where we're going to go through the critical diagnoses, the differential diagnoses of badness, and we're going to say just a little bit about what you need to ask in your checklist on your history and physical, and if there's any critical interventions that need to be undertaken if you're empirically considering these diagnoses. So let's start, sorry, wrong way. So let's start with subarachnoid hemorrhage. And this really is the quintessential emergency medicine diagnosis, right? If you don't pick it up, they might look fine. You don't pick it up, they can go home and they can rebleed and die, and that's a natural history of this. So we're really looking specifically on the history for three things: headaches that are sudden, that are maximal at onset, usually within seconds, but could be up to a couple minutes, a few minutes, and that are different than headaches that they've had in the past. Actually, that is a good entryway to talking about all of the red flags for history for secondary headaches, because it turns out that subarachnoid, as well as several of the other bad ones, present as thunderclap headaches. So those are the three key things that you have to ask. This is the only fun slide that I have in this whole section, because we're down to business for these short segments. But basically, this is just to remind you that a sudden onset explosion, so to speak, what we call the thunderclap, always needs to be worked up, because 40% of them are either going to be a subarachnoid or one of the other bad headaches. So that is the most important thing that you're looking for in history and headache. And there's just a picture of a aneurysm that's on the anterior communicating artery. You can see on the left, and then you can see it in an angiogram from the side. And that's actually the commonest site to have an aneurysm that ruptures, and so that's worth knowing as well. Occult trauma, just a few words. Obviously, trauma is one of the things that's on all our checklist. But the point I want to make here is that for vulnerable populations, I'm talking children, I'm talking elders that might have dementia or other debilitating illnesses that make them more vulnerable and needing of care. Patients in the prison population. These are patients where it's not good enough to just say, did you have trauma? You need to wonder if there's some degree of suspicion there. And if there's suspicion, you need to image these patients with some type of neuroimaging. And so there's just an example of a patient who wasn't a very good historian, was an alcoholic, and actually had significant trauma. I'm not sure if it was self-induced from falling or what, but you can see on the CAT scan that he has bilateral subdural hematomas, and they're probably a week or two old because they're starting to look about the same density as the brain itself. And that's actually kind of scary because you can miss it if you don't look carefully. So that's what they call a bilateral isodense subdural from trauma. But again, the point is if you didn't suspect that the person might have trauma that they didn't report, you wouldn't get that diagnosis. Bacterial meningitis, obviously, is one of the big elephants in the room here. Sometimes these patients will present altered, and it's kind of down a different algorithm. But when they do present with headache alone, you might not have much time before they go on to being really septic and not able to answer your questions. I just wanted to bring home a few points here. The first one is that one of the objectives is to say, how do you interpret a CSF? Well, this is how you interpret CSF. If it doesn't have no cells in it, if it's positive either with blood or with white cells of any kind, you're done. You're looking at a more complete workup. You're looking at treating this patient empirically, and you're kind of done. If it's blood, it could be a subarachnoid. If it's pus, it could be a viral or bacterial meningitis. We always assume bacterial at first and send cultures and treat empirically before we know for sure. And then the last thing is if there's blood and pus together, and we'll get to that slide in a second, but you might think about herpes encephalitis because it tends to cause a hemorrhagic type of meningitis. So just a few things about meningitis that you might forget is that steroids, if you're really thinking that this is a diagnosis, need to be initiated first or at the same time as your antibiotics that cross the blood-brain barrier, like ceftriaxone, to kill the organisms involved. And we're talking about strep as a number one organism. Ceftriaxone should cover that in most cases. Vancomycin does need to be added, however, at the point where you see that there's lots of cells. If you've got a positive tap, you need to add vanco. And the reason for that is, number one, because there are some ceftriaxone-resistant strep pneumo, which is a commonest organism, and also because some of these infections will be from Staph aureus. The other organism I didn't mention that commonly causes meningitis is N. meningitidis, Neisseria meningitidis, which is common in dorm room and military barrack outbreaks. The last thing I'm going to mention is if you do start vancomycin for a positive tap when there are cells, you start acyclovir when there's a negative gram stain. So for example, if you have a positive tap with cells, especially if you have red cells and white cells together, and there's no gram stain, there's no bacterial organisms there, you ought to empirically start acyclovir, because it's likely that you're dealing with a viral meningitis, and acyclovir treats herpes meningitis, which is one of the treatable types of viral meningitis. If the patient is altered, and they're starting to lose consciousness and their Glasgow Coma Scale is going down, that's not the time to do an LP without a CT. Generally, I always do a CT before an LP, no matter what I'm working up, but if you do want to do the LP first approach, it can be acceptable, but you have to first make sure that the patient doesn't have a descending level of neurologic status, because they could be herniating, and you ought to check the pupils to make sure that there's no papilledema before you do that. And then if there is any of those things, you should proceed to a CT first. You can always start all the therapies that we talked about empirically. You don't have to have the LP done, and then you can do the LP once steroids and antibiotics are already on board, because it is a race against the clock and you need to go fast. So don't delay your critical interventions like the steroids, like the antibiotics, for the treatment, for the LP, pardon me. This is just a nice image I wanted to show that shows herpes encephalitis. You can see that it's a hemorrhagic process that's happening at the in the temporal regions, in the temporal lobes, and the temporal lobes actually end up turning into this kind of hemorrhagic soup. It's disgusting, but you can see why they're going to have lots of blood cells on their LP, along with the monocytes and lymphocytes, the white cells that they typically get. Temporal arteritis is another critical diagnosis. This is a one to think about, generally speaking, in older white women. I mean, this is not a disease of young people. It's not a disease, generally speaking, of Latinos or African Americans. And so you don't have to be too suspicious in those demographics. But in an older person, you know, anyone over 50, you should think about this, especially females of white, Caucasian sort of background. And the thing to know about this is that if they have any symptoms of visual disturbances that you haven't characterized, along with their new onset headache as an adult, if they have any tenderness or nodularity in this area around their arteries, and you can see that you can see an artery there, whether or not it's tender or nodular, I don't know, but if it is, those things require that you put them on steroids empirically right away. They need to go on prednisone right away, and later on they can get the biopsy. It's only in patients that don't have the suspicious, really suspicious signs, like the right demographic and the nodularity and the tenderness here. The other one I would add to that is jaw claudication, which is kind of an angina of the jaw. If they don't have those classic features, then you can go ahead and do an ESR and a CRP, and if your ESR is low, you can stop. But in patients with those suggestive symptoms, you must go straight to empiric treatment, because the ESR in that case is not that helpful. It could be falsely negative. Carbon monoxide toxicity, generally, people miss it all the time, and that's the headache that presents like a flu, especially when the whole family comes in with the flu. Because they're in the same environment together where there's a carbon monoxide leak. Maybe it's a heater in Minnesota. Maybe they're doing barbecuing that's too close to inside. The reason that I show a picture of a dog here is that often you can find the right answer to the question by knowing if the dog was symptomatic. And they might tell you that. Dogs will get the same symptoms as they get if it's carbon monoxide poisoning. But because dogs don't get the same flus and colds that humans get, if it was just a flu that the family had or a cold, the dog would be fine. So the dog being symptomatic actually is the key to getting some of these right. And then, of course, the treatment for that is hyperbaric oxygen. And we're not going to go through the actual criteria for treatment, but you need to be aware that that's possible treatment they're going to need. Acute glaucoma, you know, I just want to say that everyone always thinks this is crazy. Why should this ever, like if you notice that a person, you know, they say they have a headache and you look at them and you see that their eyes are bulging out of their head, you know, wouldn't you notice that? And the reason I mention that is that you do notice it if you look at them, because they're going to have a red eye, they're going to have a steamy cornea. I mean, this is not subtle, mid-dilated, non-reactive pupil, that type of stuff for an acute angle closure. But if they walk into the triage area and quickly we're saying, oh God, that guy has a severe headache of new onset and so on, they might send them straight to CT, and 2 hours later you're like, oh my God, I should have been on this earlier with drops and calling opto and stuff. And the way you start treating this is with drops to decrease aqueous production, because using pilocarpine once the pupil's already stuck won't actually work. And so the first treatment is going to be aqueous production reduction drops. Cervical artery dissection presents basically like it presents like a subarachnoid hemorrhage with a thunderclap. The thing here to think about is that if your CT and LP is negative, and they're really referring to pain that's either really sharp in the front or sharp in the back, you ought to think about this if it's a lancinating sharp pain, because the complication of this process, This is just one of the ways you can get it, by the way, is at the chiropractor. The complication is that injury that you cause in the little intimal tear, the dissection, is the nidus for a thrombus. And so interestingly, the treatment for this, after consultation with the neurologist and making sure that you're dealing with the right thing, is actually can be anticoagulation. So that's kind of counterintuitive that a dissection would be treated with anticoagulation. It doesn't take much trauma to cause a dissection. It could be just from dancing or doing yoga. In fact, we notice that this is something that happens more with minor trauma than major trauma. Especially if the patient has a connective tissue disease, like they've got Marfan's or something like that, you really need to be suspicious about this. Cerebral and dural venous thrombosis also can present as a thunderclap-like headache and might also be something that you're looking into after a negative CT and LP. This is something that you should think about in women at the end of their pregnancies or just after they've delivered, because they're very hypercoagulable at that point. I'd also consider it in a patient who's severely septic and dehydrated in the ICU, that has new neuro findings, and in patients that have had a big history of clotting, like P's and DVTs, lots of them, they might be susceptible to this. And it's a hard diagnosis to make on CT. It might not be apparent on CT, but it might be noticeable. If you can look here, you'll see that there's an area at the back of the brain where you see that the confluence of the sinuses, the dural venous sinuses, is white instead of black because there's a little clot in there. And then when you put contrast through, it's the opposite. It shows up as dark because contrast won't go into the area where the clot is. That's a little hard to put on an exam, I think, and it's not reliable on CT. MR is the right answer in terms of how you make the diagnosis definitively, MR venogram. That's just an example of a CAT scan of someone where they did pick up a cerebral venous thrombosis, where you can see that there's clot in the dural venous sinuses at the back. And that doesn't, the symptoms that they get from that are not going to be like typical stroke symptoms. You might have non-anatomic, it might not seem to make sense anatomically. You might get, both legs weak because you've got clot that's straddling both sides. It's non-anatomic because it's in a venous, not an arterial distribution. Anyway, these patients are usually pretty sick, and usually nothing makes their headache better, and you can be onto it by that and by the fact that they've got those hypercoagulable risk factors. This is just what the MRI looks like. Much more obvious. You can see a big, huge clot running along the sagittal sinus there. Space-occupying lesion, you're not committing malpractice if you miss a brain tumor in the ER. But if someone comes in, especially if they're over 50 and it's a new onset headache, metastatic diseases being the most common thing in that demographic with that description, it's probably worth doing a CAT scan in that situation to make sure that it's not at least a big tumor that's making space, that's causing shift and putting the patient at risk for herniation. So the key word here is progressive, and you can see there's an example of a tumor with the edema and the mass effect. If you do see this with tumor, with mass effect and edema, you're going to want to call neurosurgery. Decadron in almost all cases to decrease the swelling is indicated as one of the first steps. Cerebellar infarct, these are patients that present with a sudden onset headache and vertigo and dizziness. And the CT might be completely negative. You might have to do an MR. I'm just showing you this CT to show you an example of how swelling can deform the fourth ventricle, which would make you immediately very concerned about that patient needing a neurosurgical intervention. Idiopathic intracranial hypertension is basically a disease, especially on the examinations, of overweight, often African American younger women. They have constant headaches that just don't seem to go away. They're intracranial pressure headaches, so they follow some of those rules. And the treatment is that after you CT them and the CT is negative, which it will be, you do an LP, and it both shows a high pressure, diagnosing it, and then it relieves that pressure by the fact that you're doing it, and they feel better. And long term, they will need a shunt to keep that pressure down. I show you this stimulus picture for IIH because it's this woman's trying to look to her right, and she can't, or sorry, look to her left, and she can't because she has a left cranial nerve palsy on the left side. You see that eye's not moving over. And a 6 nerve palsy is a false localizing sign. It sounds like it's going to localize it to a certain area. Oh, it's a 6th nerve on one side. But in general, the 6 nerves being so long and thin can get knocked off just by a general increase in intracranial pressure. So that's important. So a 6th nerve could just represent general increased ICP as well as a focal lesion. And that's one of the hints in this patient if they show you a young woman with this constant headache that's progressively worse. I didn't mention, but visual changes and blindness because of that pressure are one of the real side effects, and they need a shunt to relieve the pressure. Sometimes they need fenestrations in the back of their eye to relieve pressure as well. Pituitary apoplexy is just basically when someone has a tumor in their pituitary gland and it suddenly infarcts or bleeds. And you're not, that's something that you're going to think about in a more specialized population, especially ones that already have a diagnosis of a brain tumor that suddenly get worse. That might only be visible on MRI if it's an infarction. Usually if it's bleeding, it'll be visible on a CT. And that's just an example of a CT with a pituitary lesion right above the Turkish saddle, the sella turcica, and you can see the red you can see the red arrow pointing to the white bleeding, and that's pituitary apoplexy. So that would be a sudden onset headache, and visual disturbances would be the hallmark of that. And preeclampsia, God, I didn't realize how long this list was. Preeclampsia, basically you should think about in any woman that comes in with a headache, whether she's delivered the baby or not. And so the commonest thing actually in terms of missing this is a woman in her first month postpartum, and we all think, and she's got a headache, look at her, right? And she's like, oh, you got a headache, you're carrying the baby, you got back pain, you got a headache, of course. Wait a second. When you see a woman come in just after having a baby and she's got a new onset headache, you must think two things: preeclampsia, and so you should ask her all the preeclampsia questions, check the urine for protein, check the pressure. If you're not sure, call OB and start her on magnesium while you're waiting for stuff to come back. And the other important diagnosis we mentioned is cerebral venous thrombosis. If she's got a new onset headache that's unremitting, you may have to do an MRI or MRV in a patient like that. So that rounds it out. There's a lot of diagnoses, and just to summarize, 98% of these people are going home, so get the pain better. Doesn't matter what gets it better, get it better. And then basically go through that list of diagnoses and those H&P findings, and you'll basically get this right almost all the time. Thanks a lot.